Good morning, ladies and gentlemen. Thank you for the introduction. My name is Anna Ouřadová, and I work as an internal medicine resident at Královské Vinohrady University Hospital in Prague. And it's an honor for me to present you here the case of a young 34-year-old woman who presented to our emergency department for acute abdominal pain located in the right upper quadrant. There were no other symptoms or conditions present. On physical examination, the patient was hypertensive and she was pale, but with no clinical signs of Cushing's syndrome, and there was tender palpable mass in the right upper quadrant, but without rebound tenderness. She was so far overall healthy. And routine laboratory tests revealed severe hypokalemia, mild anemia, and coagulation parameters were normal. So we immediately performed an abdominal ultrasound followed by a CT scan that revealed, and I'm sorry, I have the pointer here, revealed a bulky tumor. I'm gonna continue like this. Bulky tumor arising from the adrenal gland, from the right adrenal gland, infiltrating the inferior vena cava with active venous leak and forming a perirenal hematoma and multiple lung metastases and segmentary pulmonary embolism. So we immediately started to treat the patient. We stopped the bleeding. We initiated anticoagulation therapy to treat the pulmonary embolism. We initiated excessive combination antihypertensive therapy up to these dosages. With a good clinical effect, and we substituted the patient with potassium massively, first parenterally and then orally, with only limited effect. So while stabilizing the patient, the diagnostic pathway had begun. So we started with a core needle biopsy of a subpleural metastasis. It is of note that this was a limited sample size, but it was, from our institution, it was in first place considered a metastasis of a malignant paraganglioma or a pheochromocytoma based on these findings. But extended laboratory tests revealed that both normetanephrines and metanephrines in plasma and urine were in normal range, as well as aldosterone and renin were in normal range. Chromogranin A was only slightly elevated, but surprisingly cortisol and ACTH levels were low, suggesting there was a secondary hypocortisolism of unknown origin that needed hydrocortisone substitution. And even scintigraphic imaging, MIBG scintigraphy and tektotide we performed showed physiological distribution. So we felt like there was still a piece missing in this puzzle. So we performed additional tests. And here we were finally lucky. These tests were focusing on steroid hormone precursors, and we found a massive overproduction of 11-deoxycorticosterone, more or less explaining the secondary hypocortisolism and excessive mineralocorticoid hypertension. So at this point, we decided to repeat the biopsy, but this time from a vetch resection, from a videothoracoscopic vetch resection. But even in this time, it was the review from our institution. It was considered a metastasis of a malignant paraganglioma or pheochromocytoma. So we worked with this primary working diagnosis of a pheochromocytoma and started oncologic treatment with the multikinase inhibitor, sunitinib. But unfortunately with no effect or even progression. So based on these very contradictory or inconsistent findings, we decided to ask for a second opinion from a more specialized clinical and research facility in the National Institutes of Health in the USA. And here finally, Professor Pacak's team re-evaluated the biopsy as metastatic adrenocortical carcinoma, based on some of the contradictory findings. So we switched treatment to mitotain and a combination of chemotherapy. Unfortunately, the chemotherapy was then soon discontinued due to neutropenia. And on this treatment, we finally reached regression. So at the moment, the patient has normal blood pressure. She does not has normal potassium levels. She still needs anticoagulation therapy and hydrocortisone. Mitotane dosages had to be repeatedly adjusted according to its levels, very oscillating levels. And so maybe surprisingly, the DOC levels are still very high. So for next future, we are considering adrenalectomy, or in case of further progression, then adding cisplatin. But what we really learned from this case was not only the importance of a multidisciplinary team, but maybe more that we should never be ashamed of asking for a second opinion from maybe a more specialized or expert team or institution, especially in rare diseases and rare cases like this one. Thank you very much for your attention.
Well, another excellent presentation. It sounds like mystery novels, each one of them. I have to remind myself about chair of our department, Dr. Crowther, who is hematologist, who taught me the principles of hematology consultations. And the first principle is never ask the question you don't want to hear the answer to. The second one is never anticoagulate bleeding person. So I congratulate you that what you actually had to do. Dr. Preptani, Professor Preptani is our endocrinology expert. Do I see him somewhere? Ali, you will get a microphone in a second.
Thank you, Dr. Ouřadová. That was an excellent case with a lot of teaching pearls, actually, more than the ones you listed up there. I think I wanted to ask you a question. There was one really important biochemical clue that can really lead you to the diagnosis here. I'm going to date myself. History is still, I think, 99% of your diagnosis that leads you to doing further steps. But what is the one biochemical clue that really should point you away from a pheochromocytoma or a chromaffin cell-secreting tumor? It was on your first line. And when I saw that biochemical clue, my whole differential diagnosis completely shifted.
You mean both the normetanephrines and metanephrines?
Those were negative, but on your first slide, there was a biochemical, there was a significant low level of potassium.
Well,
When
sure. Yeah.
When you see a potassium of 1.7, your differential diagnosis is very, very narrow. The fact that she had negative metanephrines excludes a pheochromocytoma, and that didn't account for her hypertension. So that's a really important clue to, I think, pay lots of attention to simple tests rather than, CT scans. And no offense, Dr. Dobrowski, but imaging should always come after biochemical confirmation, and that was a big teaching point there, right? The potassium really led you away. And adrenocortical carcinoma often does present with functional tumors, whether it's Cushing's, mineralocorticoid excess, which is the 11-deoxycorticosterone. So I think that from the teaching end, the potassium was a big clue here that this is not a pheochromocytoma. Normal metanephrines, no headaches, no sweating, no palpitations, and her hypertension was purely based on mineralocorticoid excess. So it was a great case to really think about. And I think the other point that you made, which is really important, is the hardest pathology to read is endocrine pathology. Even if you have a pathologist, we actually ask for expert opinion from an endocrine pathologist because we really need to really pay a lot of respect to endocrine pathology. It can be very fooling, and you really want to get a good opinion with transcription factors, immunohistochemistry on the histological stains, the H&S stains. So congratulations for a very complex, fortunately, we had the right answer at the end of the day.
Any questions? Any more questions? Professor Nandini.
Thank you for this very interesting case. I would just like to ask you, this patient showed an obstruction of the inferior vena cava, is it not?
A partial obstruction, right?
Okay. So clinically, how would you suspect an obstruction of the inferior vena cava when you see a patient? What will make you suspect?
She could have hepatosplenomegaly or even ascites, but she had none of these. So we did not really suspect.
And what else?
From inferior vena cava obstruction.
Yes.
Sorry.
Okay, thank you.
Professor Nandini, in a true
Yeah,
master
I
spirit,
understand.
please educate
I
us.
understand. So, a patient who is, there's a name for it actually, which is
The
called a
Budd-Chiari
Budd-Chiari syndrome.
Okay, so-
Yes, your patient could be, first thing is that he or she will be having a congestive hepatomegaly, there will be splenomegaly, and most importantly, you should look for veins which are engorged, often at the flanks or at the back. And the flow of the veins also will be from below upwards. So that's a clinical sign, and the patient may also come with edema legs. So these are subtle things, and your patient obviously had many more important near-fatal complications, but this is just, I wanted to add.
Sure.
Thank you for your comments. I just wanted to add that at the ultrasound, there was no hepatomegaly and there were no distension of portal vein, etc. So we weren't really focusing on that.
Excellent. 30 seconds more.
It was partial, yes.
Thank you very much also for a great case. I mean, this hypokalemia, I couldn't agree more. I mean, maybe I missed it. I would like to see maybe in the presentation the ECG would be nice. The ECG, I would love to see an ECG of this patient. How it looks like.
I'm very sorry.
Yeah. But the other question I have, probably you did a sequential introduction of the antihypertensive blood pressure lowering drug. So my question would be, when you started the spironolactone, did the blood pressure drop after you starting spironolactone significantly?
Significantly,
Yeah.
yes. And then after stopping spironolactone,
Yes.
it was very difficult to adjust the mitoten levels. Then they were very oscillating.
Okay, thank you.
Thank you very much. Anybody who wants to see the EKG with hypokalemia is welcome to look at McMaster textbook of internal medicine, which is available free of charge
Thank you very
to all participants of this conference. Thank you very much.
you.